This is Lou Schoen from Baltimore, Maryland, USA, giving you a lecture on foot and ankle physical exam. I will also do a special section on the telemedicine exam. So I hope you enjoy it and learn something. First, when you're doing a physical exam, you have to have some correct tools. So as you see, we use a tuning fork, 256 tuning fork, which can be used to check vibratory sensation. We will use a reflex hammer to check reflexes. We will use a tape measure to measure circumference. We use some Semmes-Weinstein monofilaments to check for pressure discrimination. We'll use a Doppler. We use a 2-point discriminator, a stethoscope, and a vice grip. Well, so much for that. We're going to look at the patient first walking away from us and then towards us. So here we're watching the foot progress through, going from toe off to heel strike, watching the toes move, watching the arch and what it does. Does she go into valgus? Does she go into varus? What does the heel do? And now we're looking at the foot, looking for any irregularities of the skin. We look at it from the front and from behind to look at the heel alignment. We also will have the patient rise up on their toes to see if the heels go into varus, as they should with an intact posterior tib tendon. Also, we're looking for coordination, and we're looking for patient's balance and ability to use other tendons in the foot. Now I'll have them stand in a perspective on the side view so I can see the arch height on the medial side and the lateral side, looking for deformities. I will also have them stand in this turned out position, which is for dancers a demi-plie position, but I will also have them do it to look at their foot, again, looking for deformities, looking for the silhouettes of their tendons, looking for the bone contour. Now, if the patient is wearing a bandage at the visit, you should always remove the bandage. It's very important. You don't want to have a bandage on, but you have to pull very carefully so you don't injure the patient taking off the bandage. But seriously, we're now going to look at the foot and do some basic range of motion. So we did a dorsiflexion with 20 degrees of dorsiflexion, plantar flexion, 60 degrees. Now we're doing inversion, eversion. Now we're going to stabilize the heel and see the transverse tarsal movement with about 20 degrees of eversion and 40 degrees of inversion. Now I'm moving my hand down towards the navicular-cuneiform joint and now the metatarsal cuneiform joint, and testing the range of motion of these joints, also the range of motion of the toes, dorsiflexion, plantar flexion. Now I'm going to do a quick test of the inversion power. And this is not just for tendon power. This is for muscle power. I'm thinking about neurologic. I'm thinking about the muscles. I'm talking about tendon and overall function. Now I'm having her do a dorsiflexion, feeling the anterior tib tendon, and now testing all the extensors of the toes and the flexors of the toes. Now we're going to have the patient do a eversion against resistance and checking for power of the perineals. Now I'm going to look at the plantar tissues to see, does she have good fat pad? Are there calluses? Are there any lesions? Does she have good integrity of the fat pad? Is there any points of tenderness? Are there any irregularities to palpating the skin? Now, when I'm doing the physical exam, I'm not just thinking about the skin and the tendons. I'm also thinking about the bones and joints and what is going on beneath the surface. And I think this is a really critical part of the exam, is to be thinking not just on the surface, but really deep down. So when you're doing an inversion, eversion, holding the talonavicular joint stable, you're now doing navicular cuneiform stresses or metatarsal cuneiform stresses. And you're thinking as you hold the foot there, what is moving deep down below. Now I'm just showing you range of motion of the toes. I'm also thinking about the contour of the foot. I'm thinking about the metatarsals. I'm thinking about the lateral column here, the cuboid and the fifth metatarsal. So when I examine, I'm penetrating my mind to the deeper structures and trying to distinguish with my fingers between the deeper structures, the more superficial structures, the topographic anatomy, and what is on the skin. So let's do that again. Plantar flexion 60, dorsiflexion 25. Now I'm doing eversion, 25 degrees of eversion, 40 to 60 degrees of inversion. This is passive motion, of course. Now we're going to do passive inversion and eversion with the foot, with the calcaneus held. So I'm doing eversion 20 degrees,